an important aspect of this whole social determinants and health has been the area of inequalities. And I think what I'd like to foreground is to really not begin with the Commission story, the Commission for Social Determinants in Health, but to sort of landscape historically the interest that has always existed and the empirical work that has informed the relationships between inequality, poverty and health. And the reason I want to take a historical take is that in all our societies, or even if we are not social scientists in public health, if we are even practitioners of public health, we have observed this empirical association between inequality, poverty and health outcomes, and also inequality, poverty and access to health services. So the distinction I want to make in this lecture is, one, we look at inequality in health, but we also look at inequality in access to health services. Now this is the kind of framework that even the Commission for Social Determinants in Health has tried to draw. And they foreground, and this is something that the Centre has been, I think, pioneering for the last 30 years, to really look at, one, what are the socio-economic and political determinants of health. So therefore you don't look at illness or health as pure biological phenomena, but you actually see them as constructed within the context of societies, where the role of history, sociology, economics and politics come together. Secondly, it is also important conceptually to look at how health services themselves are a determinant and how they are also determined by the socio-political context in which they emerge. Just to give a very quick example, if you look at countries in large parts of eastern side of Africa, I would say, if you look at the experience of Zambia, for example, or if you look at Tanzania, they're very different types of health service systems. Now, one of the things you can do is to describe them. What is the bed strength, what are the arrangements, what are the levels of care, what is the nature of access and all that. But then the question that we are really asking in this lecture is, why is this so? Why are there variations across countries? Why are there variations within countries? So the issue of variations become very, very important when you're looking at inequalities. Now, so whether you're looking at health outcomes, and in this case you can use mortality as an indicator, and you look at averages for countries. But one of the debates within inequalities, which has been very informative and in informing a lot of public health work, is to say, yes, averages exist, but averages also mask inequalities. That is, if you disaggregate mortality indicators and use variables for its disaggregation, suppose you take income as a variable, or if you take occupation as a variable, you can take ethnicity as a variable, you can take race, you can take, in the Indian context, caste, you can take many variables and then disaggregate it, regional, rural, urban. We know that. I mean, a lot of work by demographers has tried to do that using large data sets. And we do see differences. We do see variations. We do see that this average, in fact, hides many of those inequalities. So, the relationship between inequalities and health, therefore, or inequalities and access to health services, is something that is it's like a set of empirical observations will make you stand up and say, yes, there are these inequalities that exist. Now, when you look at it historically, 19th century England, you find a number of surveys, which are, interestingly, there are some early epidemiological surveys, but there are also a genre of social science surveys, which looked at poverty. So in both these sets of surveys, and the names that you have are Chadwick, you have Wilhelm, you have several other studies, the work of Frederick Engels, and the 19th century surveys of Roundtree, etc., where they saw how industrialization had given rise to large amount of urban poverty, and that this poverty was associated with poor health outcomes. So there was this kind of conceptualization which saw very clearly the association even Chadwick's work on the condition of labouring population in Britain, clearly showed the association between poor working living conditions and higher risks of mortality and morbidities, lack of access to adequate food, etc. So you had in the 70s this reconstruction taking place, largely through the work of McKeevan, etc. I don't want to get into that because we can raise these issues when we have a discussion, and if anybody wants clarification, we can go into that. Basically what I'm trying to say is that association was demonstrated, but the causality was not necessarily in the way in which we understand it. Not everyone really constructed a causality of it. For example, Friedrich Engels' conceptualization was poverty causes disease, but the Chadwickian interpretation was disease causes poverty. So you can see that while both saw the association between poverty and ill health, the way in which the causation was located was very different. So basically, whether it is in this country or in any other part of the world, this idea of inequality and health after the 19th century kind of receded to the background with the rise of germ theory. Basically what germ theory did was to kind of shift from the larger social structural factors that impinge on health, ill health, access to health services, to the individual. So you were looking at a particular disease being caused by a particular germ, which of course the body was very important, the individual body. So you were really looking at how technology could answer that problem. And I'm not saying that the question of inequalities did not have a place anymore in public health. I use the word very consciously that it kind of receded to the background, and they became more like explanatory variables. That is, you would say, yeah, high levels of communicable diseases, these are the patterns, this is the way we have to handle it. Of course, poverty is a determinant, but poverty cannot be addressed by the medical care or health services. So you just found the way in which the explanations for inequalities became peripheral, or rather you stopped seeing it as a major determinant, or what is later called and described in the Commission for Social Determinants and Health as proximal and distal determinants. So the idea that inequalities are important kind of receded. Now interestingly, in the course of history, the 1970s was a period when you started questioning the limits of medicine. And this I really want to talk about. There was a very strong critique of the medicine, technology, and you had a genre of writing where McKeevan has won, but more importantly, the feminist movement, questioning what are the medicalizing of childbirth, for example, or Ivan Illich's work on iatrogenesis, that is, medical industry itself can create illnesses, is an idea that was brought out. And psychiatry, that is, anti-psychiatric movements, or rather radical psychiatry movements, question the limits of psychiatry and the knowledge of biomedicine as applied to mental illness. And then raise this question, and which is a very important question, that you're not looking at what causes illness. And medicine alone cannot really give you answers. This had another strand to it as well, which is that there was a great deal of faith with the rise of the germ theory era that you could control communicable diseases. Here an India-China comparison is very, very interesting and useful. 1947, 1949, we are looking at two major giants in South Asia with very similar levels of poverty. But the decline of mortality due to communicable diseases in China begins very sharply, and by 1960s, they have really done away with communicable diseases. 60-65 is the kind of picture. But in India, communicable diseases continue to persist as the single largest cause of mortality during this period. So in a sense, I'm using China and India to illustrate two ways of understanding mortality declines. In India, as we know, we really invested very heavily in a techno-bureaucratic kind of a model where we said that we will take this affront using a lot of military euphemism. That we will attack, we will consolidate, we will do surveillance. So, you have this kind of a model where you didn't address, I'm not saying poverty was not addressed, but poverty was addressed as yet another program. So we had, as you all know, and especially those from Nigeria know that, the Indian experience of poverty alleviation has influenced the decolonized world, post-colonized world significantly. But having said that, the way we handled it was to really rely mostly on technology. So whether you look at malaria control or any of the other vector-borne disease control programs, we were heavily supported and funded by the WHO. We were given a lot of technical assistance from the Soviet Union also at that time, since we were a bipolar world and we sort of said we were non-aligned. So we got both. And interestingly, the decline didn't happen. Yes, it did happen, but then it went up again. So what is the lesson here? So to me, it epitomizes two approaches to social determinants in health. One which excessively places faith in technology to resolve a particular pattern of disease, to intervene. That doesn't mean we don't need medical care. But the way the Chinese did it was very different. Interestingly, they did not have health services in place. They began with what they called as epidemiological stations. Then they had maternal and child health services. It's only much later that they built hospital network. So what did they do? The preventive work was done actually by the Communist Party itself, that is the cadres. And I don't know if any of you are familiar with this John Horn's book called Do Away with Pests, where it became a political campaign. That is, they really eliminated vectors in a very serious way. The other very important aspect that they addressed was inequality, which was through land reforms. Through radical land reforms, assured work, assured employment, and what is described by this author called Elizabeth Kroll called the Iron Bowl. The whole idea of the Iron Bowl was food security. So their understanding was that we have to handle this first before we get into the story of technology. If you look at any of their disease control programs, they do have technology, but it comes as a secondary. They first address these, and to me that's a very telling example of where do you place your priorities when you talk about social determinants in health. So the Chinese, therefore, the argument is, and there is this lot of writing on this, which is of course not the dominant genre of writing. There is a common saying that if you fill your stomach, then you won't, what it basically says, a full pot is the best prevention for malaria. These are empirical observations that people have made, have understood the relationship between hunger and disease. So you find two very, very different perspectives by which this question was addressed in two very large populations in this societies with very large population. And I find a lot of this debate going on in Africa as well, especially when you compare Francophone Africa with parts of Africa that have seen British colonialism. So, the whole colonial encounter itself and the nature, the manner in which it denuded resources and created inequalities. So this is just in a way of an example. Now, if you look at the literature, you find that inequalities come back on the agenda really in the 80s. So the period of the 70s, as we all know, is states, you should cut back on investments and we should have more markets, that is the way to go. But those kinds of measures, which many of us who are in third world countries know very well that the World Bank was a very active player in this, the structural adjustment programs, the health sector reforms, which really pushed for privatization and commercialization in a big way, not just in health services, but in the economy as a whole. And therefore, it did give rise to inequalities which were very, very visible and palpable, empirically demonstrable. And in fact, the Cornea and Giovanni Cornea write a book which is called Structural Adjustment with the Human Face, where they acknowledge these inequalities, not just in health, but in child survival, in various other parameters. And so there is this discontent with this paradigm of development. And in that context, what you really find is an interest in looking at inequalities, where you're looking at global inequalities. So there is, if you, in fact, I did a systematic search for that period, and I find that there are lots of studies which are showing you, for example, inequalities in child mortality outcomes, inequalities in infant mortality outcomes, where they're comparing the developed and developing, and within developing, they are trying to compare and see where do countries rank in this particular. So there's a largely descriptive. You have a lot of descriptive statistics which are telling you that there are inequalities, these are the kinds of gaps you see. So a lot of that was done across countries. Now what is important is that these are largely descriptions. They're telling you gaps. They're telling you what is described as variations across the developed and developing world, and they're basically trying to make the argument that the developing world is really in a serious crisis if you use health outcomes as indicators. Now one of the formulations at during this period was that you can actually look at mortality outcomes and variations in mortality outcomes as mirroring socioeconomic inequalities. So, you know, you can actually, through the health status of a population and looking at variations in health status of a population, you could raise the question, which clearly goes into the realm of sociology and you know, social anthropology, social sciences in general, where you start looking at how do we theorize this? Do we just see these as artifacts, or do we really, if we have to address them, where do we need to address them? What is the nature of the structural inequalities in society? So you are looking at relationships of property, you're looking at resource allocations across access to resources of various kinds, and you are looking at the question of income inequalities very seriously. Now, therefore, you find another genre of writing which starts looking at these associations. So the relationship between income and infant mortality. So you're trying to use data sets in order to establish this association. And this is, I don't want to labor on this because this was fairly well established by then. And a lot of the work that was done in the 70s in Britain, where they brought out this inequality issue in a big way. And as you know, the Michael Marmot's own work was one, but also the Black Report was another, and there were a group of, very small group of social scientists who tried to ask the why question by theorizing, or rather bringing sociological theory to speak to public health. Now I think that is a very significant moment, and it is not just the British. You find this in the work of Krieger as well. I mean the American Harvard School, not the entire Harvard School, but there was a strands of this kind of thing, and also in many of the European, and Bielefeld is one such example. Oliver and his colleagues have also been looking at some of this. So what you find is a group of social scientists, epidemiologists, public health people coming together to ask this question of investigating social inequality and health. And it is here you had different theoretical perspectives that informed it. So there was a very critical public health which drew largely from a Marxian understanding of explaining ill health. They also used the concept of class as being the most important. But there was also several other streams where, you know, you used Durkheimians. Durkheim was a sociologist who wasn't looking just at individuals, but he was looking at societies and collections of individuals. He was looking at institutions. So you have those social scientists also trying to theorize this relationship between inequality and health. And therefore it was a very rich period of few people, but few people who are investigating and unpackaging inequality and health and going beyond what demographers and others did, including economists, who were just showing you patterns. They were showing you variations, They were showing you various kinds of axes of inequality, but they were not really offering an explanation as to why these inequalities exist and what kind of concepts can we actually use to investigate this. Now, one of the problems with taking variables and mapping them to, or showing the association with ill health outcomes was that I would take, say for example, ethnicity. And I've been looking at some of the writings from Nigeria before I agreed to speak here. And I was really, interested, and this takes me to my second part of the lecture, which is to say that how do we, you can run a regression between income and mortality. You can run a regression to show that there's a very strong association. But one of the things that you find is that you take discrete variables and you run it across various whatever mortality indicators you want to take up to address, or you can even take access to health services, and that pattern is very clear. The poorest do worse, the rich anyway do better, the middle is not really addressed in any significant way. So a lot of the analysis has also been a rich-poor dichotomy, which I will pick up later on is a problem. If you only look at our societies as the rich and the poor, there is a very large undifferentiated middle, and those who are just above the poverty, so-called poverty line, who get completely missed out. Because I think there is what Mohammed later refers to as a gradient, and that social gradient idea is a very important one, and I'll come back to that. But coming back to Nigeria, I was quite intrigued to see that we all have these large national health surveys which have come up in the last 3 decades. Here it's called the National Family Health Survey, but you have an equivalent in Nigeria as well. And what is very interesting is there is analysis which looks at income and health outcomes, a literature that's published, but then you have ethnicity and health outcomes, but you do not have anything that speak about these complex intersections. I will come back to that a little later. But the point I want to make is that when you look at just class and health, you get one kind of a picture. But we know that that's not the only axis of inequality. So take the case of India, you would have caste, class, region, gender. You can have any number of axes of inequality. Now you can look at them as discrete and you can run them with the outcomes you're looking at and get a certain picture. But we know that we all carry those intersectionalities. What I'm trying to say is, if you're located in the urban area, if you are a woman, if you belong to a particular caste, and if you belong to a particular class, these are not discrete identities for you. So while the data sets deal with you discretely, they're also dealing with social groups. But frankly, when you do not get the complexity of this intersectionality, and this is something that is very, very important. But what I also want to say is that these macro data sets do not allow us to do that kind of intersectionality. So in fact, a lot of the work that addresses the complexity of intersectionality is being done by qualitative studies. Studies that are done maybe in a village, maybe in an urban slum, but have really focused on looking at this in a significant way in smaller populations. And I really like to bring here the work of Naila Kabir. She does not work in health per se, but as a social scientist, she brought this complexity. Now what is very interesting is, it is the feminists who brought the importance of intersectionality into play. And the reason they did it is, they felt that gender by itself was not adequate to capture the complexity. They asked a fundamental question, that if you were a poor woman, would your experience be same as a woman who is in the upper class? So what they tried to say is that you cannot do any serious understanding of inequalities if you do not look at how do class and gender interact. What kind of differences you find. So I'm just talking to you, let's look at it as layers of variation. Yes, you can do each of these variables, you you get a certain pattern of variation. But when you bring the intersection question into play, then you in fact find that it gets very, very complex. And then they said, if you're working at, then they started making this distinction of women's health and gender. Simply because the question that came up was, if you were a laboring Dalit is the lowest caste category, which is also differentiated, but to put it simplistically, it is the lowest in the caste hierarchy in India. So if you were a Dalit man agricultural laborer, how would you compare with a woman in the same position? Would a Dalit woman laborer have the same kind of health experience and access to health services? Or is it that the Dalit laboring male would be closer to a lower middle class, intermediate caste woman? So some of this work was actually demonstrated empirically by Geeta Sen, and in fact her lecture called the Saul Levine Lecture, Memorial Lecture, which was published in the Social Science and Medicine, alludes to some of these complexities. So in a sense I would say that the feminists really brought this to bear on health as well. That this notion of we need to look at the intersections, that we cannot just deal with this level of what I would call rather a simple level of analysis, a descriptive level of analysis, which then tells you that these are the ways in which health outcomes, the patterns as they present themselves. So therefore, when you come to the Commission for Social Determinants and Health, interestingly, you find, those of you who have seen the Commission's report, a kind of a schema for how do you look at the various factors. So if you look at it, it's a very, very complicated diagram where you have the individual, you have the social groups, you have the health services, you have the social, cultural, economic. So in a sense, you put in all these factors to provide a framework which says that all these interact and then they affect the individual's health. I have a bit of a problem with that kind of a framework. I mean, it's a very useful framework, but the problem here is that it is not adequately informed by social science theory. It is, to me, in a sense, a kind of a halfway house to trying to understand how social, economic and cultural factors influence individual health. But it does not give adequate theorizing, because there has been all this theory which does not get reflected in the Commission for Social Determinants and Health. On the other hand, the paper by Lucy Gilson, which is there in the Resource Network papers, where she and her colleagues from South Africa are writing a paper on health services as a determinant, is a very, very valuable input into this whole debate on social determinants. Because basically what she is arguing is that health services themselves are shaped by the historical, the socio, and the political context. And so therefore the architecture of the health services can either completely mirror those inequalities or they can mitigate those inequalities. Let me re-explain that. Meaning that you can have health service arrangements that are actually equity producing. That is, they recognize there are inequalities, they see unfair inequalities, and therefore they design their health service systems to ensure that those inequalities are addressed. So that is the way in which that particular paper is argued. So what they are arguing is, if you have, as it is, if you have a society which is unequal, and many of our societies are extremely unequal, and you have a health service system which is also designed largely to benefit the rich, then you are going to basically exacerbate the social inequalities that already exist. But if you design, and this is where the role of the state comes in, if you design consciously an architecture that actually tries to make sure that it is equity enhancing, and this is where some of the ideas of Alma Ata, the primary healthcare approach, etc., come in. They come in not directly, but you can see that that is being informed by that debate. Now, in that particular case, you are really saying that you need health services that is sensitive to the inequalities that exist, and therefore you will design it in that particular fashion, whereby even though there are stark inequalities, and those inequalities cannot be addressed by the health services, that doesn't mean that the health services don't have a role in addressing inequalities. So it is a fairly complex argument that they build. There is another paper which speaks to the Lucy Gilson's paper by Govender and, I forget the second names, Govender et al., which talks about how inequalities get embodied in the health services itself. That is, see, we only think of health services as primary health centers, sub-centers, hospitals. But if we were to look at them as human service organizations, which is a genre of writing from social work actually, radical social work, which argues that these are extremely human-intensive organizations, that they also embody hierarchies. That is, it's true of all our societies. If you were to look at what is the social background, that is, you don't look at them as technical institutions, but you look at them as social institutions, then you find that they replicate the social hierarchy of society. So if you look at the social background of doctors, of nurses, of your primary level staff, and the variations within that across regions, then you will find that they are replicating those social hierarchies. And why are we concerned about that? Along with it comes certain attitudes and mindsets. So the point that this paper is making is that they basically there isn't much work done in this, but the work that they cite and review is from South Africa, where they show that our institutions are not very sensitive to gender differences. We are extremely discriminatory in the way we look at the marginalized populations. There is actually discrimination in the way in which our institutions behave. And that is because of this complex reality of how social inequalities get mirrored and embodied in institutions, and that shapes the way they behave. I'll give you an example of this, and I'm sure this is the case for Nigeria and many other, if you look at the data, I'm sure you will, for India, is that people say, we go to the public services, but we are treated very badly. It is a question in all our various national health surveys. Now, if you have to unpackage that, there is the story of inequality there as well. That is, why do institutions, public service institutions, behave in the way they do? What is it in the nature of the way in which inequalities get embedded and shapes the attitude and behavior of people? And it's important for us to look at it in this fashion because nowhere in your medical training or in your nursing education is this aspect really highlighted. First of all, inequalities don't get highlighted. And what does inequality mean when a person accesses a service? And how do you look at someone who is from a different caste and class background than you? So, all these aspects start playing in what is now recognized in a body of literature called the interactional quality of services. See, when management, the new public management took over the discourse of quality, what did quality mean? Quality essentially was technical quality. Do we have enough doctors? Do we have enough medicines? Do we have enough institutions? Very important aspect of quality. But this is called the hard story, the hard part of the story. But the so-called soft part of the story was, how do people behave? How do providers behave? And why do they behave the way they do? And very often in that literature, you will say there is a good doctor and a bad doctor. There is a kind nurse and an unkind nurse. Yes? But I don't think it is. We have to step back and take a systemic understanding of this variation and this behavior pattern that we observe. Because it is not about that one good individual doctor or one bad individual doctor, but these are systemic issues. And it is the way in which you are socialized, re-socialize, because after all education and higher education has a role for re-socialization. But that is an aspect which is completely missing in the curriculum of the doctors. So where do you build that sensitivity? And it cannot be an individual sensitivity. It has to be a group. I mean, you have to do it at a level of a group. Now, very interestingly, for example, even racial attitudes. And you look at the literature that's come out of the US, and I'm sure Germany would be a similar case. How does a German doctor look at an immigrant in the German health services? Now, on our notions of social justice and citizenship, all of us are entitled to the same health services. We know from the Indian experience that if I walk into the All India Institute of Medical Sciences, I will be treated in a particular way. So from my experience, I'll extrapolate and say, I've received the best treatment, the doctors were very polite. But if you were an agricultural laborer from the rural area, you immediately see the contrast in the. So what I'm trying to really bring out is in the literature on social inequality and health services, we really need to be sensitive to investigate some of these issues, and that it is a matter of how a cultures of institutions created, sustained, changed, and it's a very difficult task. It's easy to build hospitals and ensure drugs, but this aspect of the interactive quality, it takes me into another strand of very interesting writing in this area, which actually came out of South Africa after the anti-apartheid movement, and after Nelson Mandela came to power, and then the whole Truth and Reconciliation Commissions. And that strand of literature again is from public health writing in South Africa, which is how do we bring back trust into public systems? Because by then there was a lot of mistrust, and the mistrust was really this interaction that I'm talking about. But the flip side of it was many poor people would argue that if we go to the private sector and if we pay for care, we are at least treated with a little more dignity than the public system. So you know there are these very, very difficult and complex sets of issues that come to play. Now, a neoliberal would say, precisely, shut the public institutions down. Market is the answer. But today we are not in that position, because we know markets do not have an answer. They perpetuate inequalities. They drive people into poverty. So as you can see, there are many voices and a confused set of voices around this. So it's extremely important for us to at least be sensitive and to understand that there is this very interesting genre of writing that is taking place, where they're looking at trust and bringing in many issues of institutionalized inequalities and how they play themselves out in hospitals, in primary health centers and sub-centers. I'm sure as I speak, you will be able to sort of get examples in your own minds from your own countries, and maybe we can have that sharing in the discussion. So coming back to the inequality studies, they're mostly descriptive in nature, including the one which has been circulated to you as a background reading. It is descriptive partly because I think now there is an interest to look at what is happening in terms of inequalities. And in this, you find that you have studies which use largely macro data sets. Like I said, the National Family Health Survey, and I know that in the US, for example, you get data collected on lines of income and race. And there's considerable amount of writing in this, including discrimination of a racial kind in institutions, both education and health. So they have gone quite a way beyond. But there is another very interesting set of literature which argues that race as a category is inadequate. If you don't bring in intersections, you will not get a nuanced picture of the dynamics of inequalities. For example, it is not as if all blacks are poor. Okay? So if you don't bring in class into it, the experience of a middle class black is very different from a black who lives in the inner city. So it is also acknowledging the dynamic and changing relationships of race and class. And if you bring gender into it, and there is a whole genre of black feminists writing on it, they bring in a very, very important angle into this intersection. And then the whole picture changes. So similarly in the Indian context, and I would think it is case of large parts of Africa, which I know not too much of, but for example, tribal identities within Africa. So yes, they are nation states, but within Africa, within African nations, you have different tribal groups who have had their own history, and they have been brought together into this idea, modern idea of the nation state. And there are a number of inequalities, just as they are in the Indian situation. So, in the NFHS data, for example, we have this category called scheduled tribes, okay, and scheduled castes. But if actually you were to disaggregate it, we have so many groupings within them that it's very hard to say that all scheduled castes have the same experience and all scheduled tribes have the same experience. Because there are some scheduled tribes who are still in the hunting-gathering state, who are even not recognized as scheduled tribes, who have been criminalized and called criminal tribes. So, you have stratification even among these categories. So, all you can do in these analysis is to give broad pictures. Yeah, SC, ST versus the others. Yes, we do see many gaps. But the others is also not an undifferentiated whole, which is what I'm trying to say. And in this particular paper we worked on, the point we were trying to really build, which Mahmoud tries to build, and it's fairly well argued in the Commission's report, is that actually in all our societies there is a social gradient. That is, the extremes are very clearly demonstrated by a lot of the inequality studies. So the rich-poor story is very well articulated. But what we see in many of these, if you do a nuanced kind of an understanding of this and really disaggregate and theorize this, there is a very large middle. And I think it is specifically the case when you look at Turkey, when you look at Nigeria, when you look at India, where the growth story has been quite good. We are not, in terms of economic growth, we are seen as, we are the emerging story in a sense. Brazil, India, China, all these countries. But there is a story of this undifferentiated middle, which is very well acknowledged in the Western literature by work of C. Wright Mills, etc., who talk about the old and the new middle class. They talk about, the role of the middle class is very well articulated. But in many of our countries, middle class is not something we talk about. We either talk about the rich or the poor. Now, this is a very important aspect of investigating social inequality in health, because in this large undifferentiated middle class, you have people who may be, in technical terms, by the definition of the poor in our countries, may not be below the poverty line, but they are living on the edge. So any event in their families can drive them into poverty, then they climb out of poverty again. So this aspect of the lower middle class, which is largely occupied by the unorganized sector, by people who are maybe even in the organized sector but in the lower ranks of the organized sector, and who have today the aspirations for mobility. So it creates many tensions and stresses in terms of disease patterns, in terms of accessing care, in terms of even experience of mortalities. And I think I'm not going to get into that, but the story of the rise of non-communicable diseases is a very important one, and Mahmoud's own work of what happens to cardiovascular diseases, which was once seen as only a problem of the upper middle class and lifestyle, etc., how there becomes a downward shift, and he demonstrates this work very adequately. So to come back to this, so we are dealing with descriptive studies, but I think we have come to a moment where both social scientists, epidemiologists and public health people are grappling with the need for theory. And this is where I really want to end my lecture, because I want to say that we can remain at the level of descriptions, we can remain at the level of empirical showing and associations, but if we really want to answer the why question, we will have to go beyond that. And in a sense, this is where it leads you to doing intensive interdisciplinary work. And if you don't speak to social theory, then there is a problem that you will continue to remain at the descriptive. And the prescription part of the story then is informed by this description where you say, yes, we should have more targeting, we should ensure that the poor don't get left out, we don't worry about the above poverty line, but we are concerned about rising catastrophic expenditures. I'm talking about the Indian situation, or even the experience of mortality and illness. So then you start having this problem of what kind of prescriptions do you give? And is it enough to go on putting more money into health services, to produce a more medicalized solution to the problem? Or do you really need to look at the way in which inequalities have grown, how they have manifested, and India is the classic story of high growth, high levels of poverty coexisting with it, and a very large undifferentiated middle which seems to be swinging back and forth, slipping back and forth, and we really don't have enough evidence to discuss this in any serious way. And I really think that if you do not have a theory, then you cannot have the why explanation in place. I think I'll stop there and let's have some discussion, questions, comments, whatever. Thank you.